Hello, today we'll deal with the symptoms of COPD, and we will mention three main symptoms. These are called the cardinal symptoms, the most important symptoms. Of course, there exist many symptoms, but the three most important ones are sputum production. We have dyspnea, and we have chronic cough. What does chronic cough mean? We know that COPD is related to chronic bronchitis, which is causing chronic cough. This is a productive cough that you have more than 3 months every year for more than 2 years. So more than 3 months for every year for more than 2 years. That's chronic cough. That's when you call it chronic. Dyspnea is the most important one of all of these three. Dyspnea, this is the first one you will see. This dyspnea means that we have difficulty breathing, especially when you have during exertion, so during a physical activity. So the patient is walking around and then he's getting difficulty breathing. And when is this happening the most commonly? During the morning, evening, or during the day? Which one is most common for COPD patients? It's during the morning time, in the beginning. Of course, when the disease progresses, it will appear throughout the whole day. And it will not only be during exertion, but it will be also during rest even. So how can we tell if the COPD patient is getting worse? You ask him, do you have difficulty breathing during the morning, evening, or during the day? And then he will tell you that he has difficulty breathing during the whole day. That's severe. Then you will ask him, when do you have difficulty breathing? By laying down or by sitting or by walking around? No, I have difficulty breathing by sitting down also, or when I lay in bed. So this is a very severe sign. And the other sign that the disease is progressing is when you see that the acute exacerbations, we call it, that means that we have a very, very drastic increase in symptoms. So the patient is getting worse very quickly. The interval between these are getting shorter and shorter. So for example, the patient was in the hospital 1 week ago, and then 1 week later he has to go to the hospital again because the symptoms is so severe. He cannot breathe anymore. The oxygen in his blood is getting so low that he's getting a panic attack almost. He is not getting enough oxygen. And when the interval of this exacerbations, we call a decrease, that is also a very, very bad sign. What about sputum? In the beginning, the sputum will be mucoid, more water-like, and then when the disease progresses, it will be more purulent time, which means it gets more yellowish and more thick, and that's also a sign. So if you think of the three cardinal symptoms, then you will be fine as a doctor. Or if you're a patient and if you recognize that you have difficulty breathing in the morning and then it suddenly appears more commonly, then it's also very, very bad. And chronic cough, you're coughing all the time for more than 3 months every year, and you are doing it for every year for more than 2 years. That's also a sign. Which activity should you stop immediately when you see any of these symptoms? Actually, which activity should you not do at all? Smoking, of course. Smoking is the worst thing here. So if you take a COPD patient, you take a chart like this and you put 80%. What is 80%? This is 25, 75%, let's say 80%. So if you consider all this part here, 80% of patients smoke. 80% of all COPD patients smoke. The other 20% is some environmental cause. So it can be, for example, fumes or organic or inorganic dusts. And this is something that you have around you. All the smoke that you have around you, all the environmental things. That's 20%, but that's only 20%. Okay, it's a lot, but 80%. We could decrease all the COPD patients by 80% by just telling them to please stop smoking. And what about smoking? When is it causing COPD? Only if you take one cigarette? No. We're talking about pack years. Pack years. Pack years means that how many packs of cigarettes do you smoke? This is a pack of cigarettes. How many pack of cigarettes do you smoke per day? Times the years that you smoke that. Okay, let's say this guy, he's smoking 1 pack per day. So 20 cigarettes per day for 10 years. then he has 10 pack years. If the guy is telling me that he's smoking 2 packs per day for 10 years, then he has 20 pack years. Okay, so you take the time, the packs per day times the years, then you get the pack year. And at which pack year is it very, very common to get COPD? The likelihood of getting COPD, the risk of getting the COPD is very high, more than 15. So when you have around 10 to 15, you are in the gray zone. Here you can get COPD depending on which genetic makeup you have. I mean, what did your parents have? Did they have COPD? If they had, then maybe you will get COPD by only smoking 5 pack years. It all depends on your genetics. There are guys who can smoke, for example, 30 pack years and they don't get anything. And then suddenly, what we call the threshold at which like almost 90 or 99% will get COPD is more than 40 pack years. That means you have been smoking 1 pack per day for 40 years. Then this number is really high, and then you will very, 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 very likely get COPD. And as we said, it all depends on genetics also. So when you hear somebody telling you that, yeah, but my grandmother, she has been smoking for 50 years or 40 years and she has no COPD, then you will tell her that congratulations, you have a very good genetic makeup. Your genes are very good, you are very lucky that you didn't get it. But please, never start to smoke because your grandmother had been doing it for 40 years and she has nothing. Please never start to, this is not an argument, please. Okay, so forget these arguments. The genetics can change also. So if you have good genes in your family, your genetic makeup can also change. It can get worse, it can be damaged. So please forget that. So the 3 cardinal symptoms. What about other symptoms that are not so, so they are common, they are important, but these are not so important. These are leaning. So if you have a guy here, he's leaning, he's sitting here, and he's leaning forward. So when you see the patient coming in and he's sitting in his bed and then he's leaning forward and he's grasping for breath, he's using his accessory muscles. Why accessory muscles? Accessory muscles means that the muscles not related to the diaphragm, because the diaphragm, as we know, here in your body you have a diaphragm, and this muscle is the most important one related to breathing. If this does not work as it is in COPD, because we will see that the diaphragm movement is not so good anymore, it's not moving, and you can hear that. If you, for example, auscultate the lung with a stethoscope, then you hear at which level the diaphragm is, and you will see that the movement is very short. Why? Because in COPD you will have a hyperinflation of the lungs. You will have a total inflation. The lung tries to get so much oxygen as possible, so it tries everything. It tries to hyperventilate, and therefore the diaphragm will get lower. You will not have movement anymore, and then suddenly the patient needs to get help with other muscles like the neck muscles, shoulder muscles. And then he will start to breathe something like this. He tries to do everything to breathe, and he starts to breathe with his shoulders and with his neck muscles. And that's the accessory muscles. So he's leaning forward, trying to do this, and he's not getting any oxygen. You auscultate the lung. Here in the base of the lung, here in the base part, because this is the chest, base part, you will hear crackles and wheezing sound. You will see that his neck vein is getting distended, so enlarged. Why? Because as we know, the heart muscle, the right ventricle of the heart, this is the right ventricle because we have 4 chambers of the heart, and the right part of the heart here, lower one, is called right ventricle. That is pumping blood into your lungs. And that means that when the lung is damaged, so that you have a disease in your lung like COPD, the heart cannot really pump against this high pressure that builds up in the lung. Therefore, the right ventricle will be exhausted, so it will be totally fatigued. This is called right heart failure. And as we know, when the pressure builds up in the right ventricle, then the pressure builds up in the right atrium, and then the pressure builds up in the liver and in the neck veins. Why? Because all of these organs are interconnected. Because the blood flow from the liver goes into the right atrium. And if the pressure is building up here, then the liver will get enlarged. And this is something that you can palpate in the thorax region. So you will see that normally the liver, if we have this, and we have the ribs here, normally you can palpate the liver here at the costal margin, and in enlarged liver you will palpate it lower. It will be enlarged and it will be tender, so you will have pain. And this is something that you can see. Also neck veins, because the pressure builds up in the right atrium, and then the pressure builds up in the neck vein, because the neck veins are going into the right atrium of the heart. So these are things that you can see. Something called Hoover's sign. Hoover's sign. This is something interesting here that you probably didn't heard here. Hoover's sign. This means that usually in the intercostal, intercostal is something called between ribs. This is a rib and this is a rib. And here is the intercostal space. The lower intercostal space, when you inhale, usually this expands. When I inhale, everything expands, my thorax expands. But in Hoover's sign, in COPD, this means that paradoxically we will have a retraction, meaning it will get smaller in diameter at the lower intercostals, so lower ribs, it will get smaller. So that's paradoxical. This is the Hoover's sign. What about the shape of the thorax? Usually the shape looks like something like this, and then this diameter here, anterior posterior diameter, will get larger. So let's say it will become this big, okay? It gets enlarged. This is called anterior posterior diameter enlargement. This is called barrel shape, okay? Barrel shape chest. Barrel shape, okay? This is also a typical sign. So these are the physical examinations that you can see. As we said, auscultation, also crackles in the base, wheezing in the base of the lung, and also decreased breathing sound. You have the patient's face can be cyanotic, meaning bluish, because he is not getting any oxygen, and so on. There are actually many types of physical examinations that we could do, but of course the most important then will be to make lung function tests, and this will be dealt in other videos. So actually, just to conclude in a couple of sentences, cardinal symptoms, remember those: coughing, you have sputum, and you have dyspnea, difficult breathing. Or if you only remember these things in this whole presentation, that's enough. And then the physical examinations, then you can remember these neck vein, the enlarged liver, and so on, the Hoover's sign, and so on. And the forward-leaning body, the accessory muscles, decreased breathing sound by auscultation, and also this barrel shape of the thorax region, and so on. I think that will be enough, and please watch this video many times, because I just mention all the symptoms quickly. If you want to really memorize them, then please write them down and then memorize them by flashcards. So I thank you very much for listening.